afternoon, everyone. I welcome you to this ESID Grand Rounds webinar, which will be on the diagnostic approach and therapies for monogenic very early onset inflammatory bowel disease. So we have a very exciting program ahead with lectures by experts in the field. The first will be by Jonathan O'Donnell on IL-10 receptor deficiency. The second by Holm Uhlig on the diagnostic approach to monogenic inflammatory bowel disease. And then finally, we'll have Aleixo Muise with ITGAV as a novel disease in very early onset IBD. I want to remind all of you that if you have questions, and I do hope you have many questions, that you will put these in the Q&A tab of the Zoom link so that we can gather those questions and ask them to the specific speaker. So with this information, I hope we can introduce the first speaker, which is Jonathan O'Donnell. And Jonathan is actually a pediatric gastroenterologist from Australia, practicing in Sydney, and now actually pursuing a fellowship in pediatric inflammatory bowel disease in Toronto Sick Kids, and also a PhD at the same time on very early onset IBD at the University of New South Wales in Sydney. So welcome, Jonathan, and the floor is yours.
Thanks very much. So hopefully everyone can see my screen, and I'm going to get started. And I've been asked to do a case presentation today on monogenic IBD. So these are my disclosures. So just to recap what inflammatory bowel disease is. So this is a chronic relapsing remitting immune-mediated inflammatory disease, primarily affecting the gastrointestinal tract with a prevalence approaching 1% in North America. And you can see there in this nature review in gastroenterology and hepatology, the highest incidence is in North America, Europe, and in Australia and New Zealand. The etiology is a complex interplay of genetic predisposition, environmental factors, and immune system dysfunction. And you can see there in the Venn diagram, you really need a perfect storm of those combinations to result in the development of inflammatory bowel disease. It's divided into two distinct entities, Crohn's disease and ulcerative colitis. And approximately 10 to 15% of all IBD patients are diagnosed before the age of 18. Now, children do have a distinct phenotype from adults characterized by a predominance of inflammatory behavior, as opposed to fibrostenotic or penetrating disease, specifically in Crohn's disease, and more extensive and more severe disease with nutritional growth complications. So suggestive of maybe a greater contribution of the immune system to pediatric inflammatory bowel disease. Now, monogenic IBD is also a subset of inflammatory bowel disease. And you can see from this systematic review that was published by our lab recently that although it's more common in young children, nearly a third of patients are diagnosed after the age of 6 and 10% in adults. There's a lot of non-gastrointestinal characteristics in monogenic IBD, with 76% of people developing at least one extraintestinal comorbidity during their clinical course, and treatments vary. So there's a high proportion of patients who proceed to bowel surgery, and also a high proportion that proceed to stem cell transplant as well. In terms of where we're situated, so we're at Sick Kids pictured there in Toronto, and we're the largest pediatric hospital in Canada and one of the largest in North America. So in terms of our inflammatory bowel disease, we manage about 1,200 patients at any one time. And we also run a precision inflammatory bowel disease and monogenic intestinal disease clinic, which reviews about 20 patients a year with monogenic inflammatory bowel disease. So onto the case presentation. So we had a referral for a 6-year-old who presented to the rooms, and the referral was for abdominal pain, PR bleeding, and a lump on the labia. In terms of her past medical history that was included in the referral, she'd previously been referred by pediatric surgery about a year ago with perianal skin tags and abdominal pain. She was diagnosed with constipation and trialed on eniperiant, polyethylene glycol, which we call PEG or Restorelax in Canada. And then she was trialed on Pico-Salix or bowel washouts, which reportedly had a good effect, and she was discharged from the surgical clinic. In terms of her past medical history, she had a normal perinatal course, she had no delayed umbilical cord detachment, she was breastfed, and she had no food or drug allergies. No previous infections, and that's inclusive of no sinopulmonary infections that were known, no previous intravenous antibiotics, and no previous hospitalizations at any time in this patient's life. There was a history of atopy, so eczema. She had normal developmental milestones. There was a non-consanguineous family history, really no relevant history on the maternal side. The paternal side had some atopy as well. There was a healthy sibling, and there was no history of inflammatory bowel disease, nor any more of the autoimmune triads, so celiac, autoimmune, liver, thyroid disease, type 1 diabetes, nor of recurrent infections in the family. So pretty unremarkable history and a pretty unremarkable family history. Now, when we saw this patient in the rooms, we found out they'd actually had a 6-month history of mouth ulcers, red inflamed gingiva, growth plateau with 5% weight loss, low energy levels, and ankle pain, which resulted in pain with walking. This patient had also had a 3-month history of recurrent PR bleeding, which was disclosed as around the stools on wiping, so distal bleeding, which resolved with reinstitution of aperients, and she'd also had perianal purulent discharge, and it had no relief in this symptom with oral antibiotics nor sitz baths, which had been suggested by the GP. In terms of the lump on the labia, she had a 1-month history of a red swollen lesion on her labia, and it had no change with antibiotic cream topically, nor thrush treatment for this. On examination in rooms, she appeared sick and uncomfortable. She was crying when she passed bowel motions, and she was unable to ambulate or sit without pain and appeared quite thin. She had oral ulcers, gingivitis, angular colitis with oral thrush as well. Cardiorespiratory examination was essentially normal, aside from some tachycardia, presumably with pain. Her abdominal exam was unremarkable, non-tender, no organomegaly, and she had a left labia to buttock abscess, which was inflamed, erythematous, draining green fluid, and really extended all the way from the labia around to the buttock. She had a perianal skin tag, and there was green stool in her nappy. So our initial workup, this is some of her blood work, her full blood count, and you'll see that there's at least an iron deficiency anemia type picture, knowing that her hemoglobin is 115. She's got a low MCH and MCV, some thrombocytosis and neutrophilia. Elevated inflammatory markers with a raised CRP, ESR, and the thrombophilia that I mentioned earlier, and a hyperalbuminemia. A calprotectin's elevated as well. So this really is not out of the ordinary. It's the classic picture we see with inflammatory bowel disease, where you see a thrombocytosis, elevated inflammatory markers, and a picture of almost iron deficiency anemia on the blood test with some neutrophilia. Interestingly, she had an elevated IgG and an IgA. The IgA is a little bit unusual for us. We sometimes see elevated IgG associated with IBD-related liver disease or IBD itself. We did perform lymphocyte subsets as well. And I think these were very interesting and a key part of her workup. So we saw that she had elevated CD3 cells, which reflected an expansion of T cells due to chronic immune activation and suggested potential decreased regulation from IL-10 signaling. She also had elevated plasmablasts consistent with ongoing immune stimulation and maybe a lack of IL-10 mediated control over B cell differentiation and class switching. In terms of her further workup, she was admitted to hospital and had an EUA, which detected a rectolabial fistula, and a CTOM was inserted by the general surgical team. She was noted during this exam under anaesthesia to have extensive perianal fissuring and surrounding cellulitis. We performed an endoscopy and colonoscopy, which noted an erythematous stomach and duodenum, and then an edematous and ulcerated TI mucosa. So the first picture is the pylorus, and the bottom picture is the terminal ileum. The colon also had a patchy loss of vascular pattern, suggestive of inflammation, and a large ulcer in the distal colon. Her histopath noted some lymphocytic esophagitis, which we often see in association with inflammatory bowel disease, a granuloma in her stomach, which is pathognomic of Crohn's disease, some active ileitis and focal active acute inflammation throughout her colon. So at this point, a VEO-IBD gene panel was sent and treatment was commenced. So we chose to start exclusive enteral nutrition first. And this is essentially a polymeric formula-only diet for 6 to 8 weeks, which has the effect of reducing diversity of bacteria in the gut. And the proposed mechanism of action is reduction in antigen presentation by reducing bacterial diversity. And this is a very easy way to get calories into a child as well, who is malnourished, as I mentioned earlier. Infliximab was also started, and we use a BSA rather than a milligram per kilogram dosage at sick kids. And we started ciprofloxacin and metronidazole for the perianal abscess. Now, her gene panel is pictured here, and this was a VEO gene panel that we sent off. And you'll see here that there are 2 variants that have come back as positive. Now, the first variant, the IL-10RA variant, maps to the ligand binding region of the receptor and is a known ClinVar pathogen variant, which is published and is predicted to be damaging with a high CAD score, which is a metric used to assess the potential deleteriousness of genetic variants, including single nucleotide variants and small indels in the human genome. Now, the second variant was a little more difficult to delineate. It maps to the transmembrane domain of the IL-10 receptor alpha receptor, and it's quite rare, but a CAD score is 14, so potentially damaging. It is quite close to a common variant affecting the same amino acid, which we thought might be the reason that it's not been documented previously. So what we thought of doing after this was performing functional testing to see whether this variant of uncertain significance, the second variant, actually was disease-causing in combination with the first one. So we got some help from the Snapper lab in Boston, and the Snapper lab in Boston performed functional IL-10 testing. So this is detection and quantification of STAT3 phosphorylation by flow cytometry following IL-10 stimulation. This assay compared the patient's cells' response to stimulation of healthy first-degree relatives and to that of a control. So peripheral blood mononuclear cells were left unstimulated or stimulated with IL-10 and IL-21. And IL-21 serves as a positive internal control since signaling through the receptor also leads to STAT3 phosphorylation. The results displayed show phospho-STAT3 expression on the x-axis in the presence or absence of stimulation. The healthy controls PBMCs respond normally to IL-10 and IL-21, detected by a shift in the p-STAT3 histogram, while the patient's PBMCs did not respond normally, seen by a lack of shift in the p-STAT3 histogram, suggesting abnormal function of the IL-10 receptor. So in terms of IL-10 alpha receptor deficiency, the phenotype is age of onset of symptoms being 1 month and diagnosis is around 1 year. Most cases are consanguineous. Most cases pass away without intervention between age 1 to 2. And the symptoms most commonly are bloody diarrhea or diarrhea. The majority have GI involvement. Failure to thrive is very common. Eczematous lesions and folliculitis is extremely common. Mouth ulcers, common. Perianal manifestations are extremely common. And interestingly, IL-10 alpha receptor has an increased likelihood of perianal fistulizing disease compared to IL-10 or IL-10RB. Rheumatological manifestations, so same as this patient with the ankle pain, are not uncommon, and respiratory tract infections, malignancy, and other abnormalities as well. So I think our case demonstrated very similar symptomatology with what's published in the literature. In terms of the prognosis, we did a follow-up colonoscopy, which was improved, and this was the terminal ileum, which you can see there's no ulcers or no erythema anymore, but there was ongoing distal erythema. We referred this patient to the BMT team to consider stem cell transplant, and then we actually used dual biologic therapy, so combination infliximab, vedolizumab, to see if this could improve some of the ongoing distal changes that you see in the colon in the bottom picture. Vedolizumab, just very quickly, essentially selectively blocks interaction between alpha-4 beta-7 integrin and MADCAM, which inhibits the homing of effector T cells to the gut without broadly suppressing the immune system, which differentiates it from non-specific immunosuppressants. In terms of evidence in pediatric IBD, the largest study is the VEO-KIDS study of 17 centres with 140 children, with rates of steroid-free clinical remission higher in ulcerative colitis than in Crohn's disease, and improve efficacy in those who are biologic naive. Now, sort of similar to the increased efficacy in Crohn's disease, we do see steroid-free clinical remission is more common in all children with isolated colonic disease rather than ileal disease as well, which is another reason why we chose to add it for this patient. There's also emerging evidence for vedolizumab in the prevention of intestinal acute GVHD after allogeneic stem cell transplant. So we used it as a priming agent as well for this patient. In terms of takeaways, I think monogenic IBD should be considered not only in patients less than 2 years old, but also in older patients with any of the very common monogenic manifestations being severe dermatological abnormalities, extraintestinal manifestations, worse disease severity. Immunological screening has benefit in VEO-IBD. So we saw that we picked up a gene and then did functional testing, and this has changed this patient's trajectory. Functional testing can assist with the diagnosis if the genes or the genetic results are unclear, and referral for bone marrow transplant may be curative in some patients. Thanks very much.
Thank you very much, Jonathan, for this interesting case report and overview of the literature. So I forgot to mention in the beginning of the talks that we would take all the questions to the end of the webinar and have them all together for each speaker. So thank you very much, Jonathan. It's now my pleasure to introduce to you Holm Uhlig, who is actually an expert gastroenterologist in the University of Oxford, where he studies very early onset IBD, but also mucosal immunology. In that context, he has contributed to many disease discoveries that have really helped us in elucidating the complexities of very early onset IBD. So it's my pleasure to introduce Uhlig with his talk on the diagnostic approach to monogenic IBD. The floor is yours, Uhlig. I'm afraid you're muted. Sorry, Holm.
Thank you so much, Isabelle, for this kind introduction. I'm just switching to... Okay. Today, I'd like to add on to Jonathan's detailed sort of case presentation with a slight overview on the diagnostic approach and the complexity of the diseases that we might find. These are my conflicts and disclosures. And our group is interested to study sort of intestinal function through the lens of multi-omic technologies to understand how genetics in the end lead to clinical phenotypes and how we can interpret this complex setting in order to drive better treatments for patients. What we have seen, as in many other fields, is in the last 15 years, a complete shift in clinical practice from some discoveries that were made by, for instance, panel sequencing approaches or candidate sequencing approaches or isolated association studies towards exome sequencing and genome sequencing in some countries, towards a standard of care very, very similar than the introduction of genomics in the field of immunology, and to highlight sort of these factors, the overlap. For instance, in the UK, we sort of screen primary immunodeficiencies, inborn errors of immunity, and monogenic forms of inflammatory bowel disease with one extended panel, indeed, because there is a significant overlap between the courses of both. Now, if we think about the diagnostic approach to these disorders, then it's very clear that in many cases, diarrhea sort of is the lead symptom in many patients. And the approach very much depends who is seeing the patient. If this is a pediatrician in primary care, then even in a young patient, diagnoses like celiac disease, typical infections, cow's milk protein allergy, or some intolerances, including protein and sugar intolerances, are the most likely cause. If you see a patient with significant and delayed and chronic diarrhea in an immunology clinic, then most likely pediatricians, gastroenterologists might have seen the patient before, and so there is a significant selection. And then atypical infections, antibiotic associated diarrhea, rotavirus vaccine associated inborn errors of immunity, enterovirus infections, severe forms of allergy, but also very early onset inflammatory bowel disease, enteropathies, forms of Behçet disease are much more likely. So your view in an immunology clinic is very much biased towards more severe disease, and the likelihood to find a genetic condition is much higher. What's clear is that the anatomic location that is affected is very much associated with the type of disease, and diseases that lead to immune tolerance breakdown are more often associated with upper gastrointestinal tract infection, whereas signaling in the IL-10 pathway defects in those conditions that Jonathan has described are almost always present in the lower gastrointestinal tract. Similarly, this physiology of the gastrointestinal tract affects the outcome, because nutrient absorption is more important for the upper GI tract. In the lower GI tract, there's more water absorption and tolerance to bacteria. The gastrointestinal tract is an extreme complex organ, and it's not just the immune system that we have to consider with all these T cells, B cells, intraepithelial lymphocytes, lymphoid structures, but also the epithelial cells that have a role in nutrient sensing, enterochromaffin cells, goblet cells, and last but not least, the function of the nervous system and stroma cell compartments that's increasingly recognized as playing an important role. And if you consider the upper GI involvement, the duodenal enteropathies, then we have a large spectrum from diseases that look like celiac disease to eosinophilic upper GI disease, lymphoid hyperplasia, and this forms a spectrum of disease. And just to highlight one exemplar, CTLA-4 haploinsufficiency, it's very common to have not only a series of autoimmunities, but also have duodenal involvement and disease. And colitis is less common. And treatment with abatacept, the CTLA-4 fusion protein, can improve a number of those autoimmune conditions, including enteropathy and including the colitis in those patients. Now, one key feature that sort of is typically associated with the diagnosis of Crohn's disease are the findings of transmural inflammation and of granuloma formation, so macrophages that are fused together to multinucleated cells. And that is one of the hallmarks, the histological hallmarks of Crohn's disease. However, we see sort of a large spectrum of different histological findings in these patients, and that is due to the increasing group of monogenic conditions that can lead to intestinal inflammation in the colon, with some Crohn's disease features and some ulcerative colitis features that affects cells of the mononuclear lines, in particulars of monocytes, macrophages that do not digest bacteria, lymphocytes, in particular regulatory T cell populations, but also a defective selection in effector T cells that then lead to an oligoclonal expansion and a response, for instance, towards bacteria, but also, as I mentioned, epithelial cells, nervous cells, endothelial cells that form part of a broader barrier function in the gut. And if this barrier function is defect and bacteria translocate through the epithelium, the mesenchymal layer, the phagocyte layers, that all prevent adaptive immune responses, then it leads to a selection of pathogenic bacteria, often Th17 sort of responses, and then a picture can form that looks like classical Crohn's disease or ulcerative colitis. What we have learned over the last decade is that a group of over 100 conditions can lead to intestinal inflammation, and the largest group individually is probably of the macrophage activation group and defective antimicrobial activity. That's followed from immune dysregulation, lymphocyte selection problems, as I mentioned. And we can increasingly systematically understand those disorders by understanding the biochemical pathways, the gene expression profiles, and by treatment responses as well. And just to highlight the fact that in about 50% of these monogenic conditions, we have some evidence that hematopoietic stem cell transplantation is successful. Jonathan already mentioned the IL-10 signaling pathways. This is probably the group of disorders with 100% penetrance of intestinal inflammation, often extreme early in the first few months of life, a classical recessive disorder that features with colitis and with perianal disease. And as Jonathan mentioned, folliculitis, other extraintestinal manifestations can be present as well. It's not just an inborn error of immunity. Recently, in a collaboration with Sophie Hamilton and Rainer Dofinger, we could show that autoantibodies against IL-10 can phenocopy this genetic condition of an IL-10 signaling defect by having neutralizing antibodies against the cytokine, and then leading to a very severe course of intestinal inflammation. And in these patients, we did genetic screening and excluded a genetic defect, found the autoantibodies, and treatment with rituximab was successful treatment. And that puts IL-10 now in this emerging group of anti-cytokine antibodies that was discussed. It's the last ESID grand round, where sort of anti-interferon gamma or IL-17 or 22 or interferon alpha, omega, IL-6, GM-CSF, IL-12, 23 is now complemented by anti-IL-10, leading in that case to intestinal inflammation. We increasingly recognize that it's not only loss of function variants, but also gain of function variants that can present with intestinal inflammation. And one group that is an reoccurring scheme in a multi-organ involvement, including the gut, are the gain of function variants in the JAK and STAT signaling pathway. For this group of disorders, there is an obvious choice of treatment. Instead of the classical immunosuppressive treatment, JAK inhibitory medications, for instance, tofacitinib or upadacitinib or others, block the overactivated gain of function genetic variant and can reinstall the immune homeostasis. As I mentioned, intestinal inflammation can affect patients not only because the immune system is defective, but also because barrier is dysfunction. And recently, in a collaboration with Bernice Loh and Ahmed Al-Shibi and Melania Capitani and Aline Azzat-Daftari from our group, we described patients in a defect with AGR2. It's a factor expressed in particular in goblet cells, and goblet cells then undergo an extreme stress. They are dysfunctional, they don't produce mature mucus, and probably by affecting the mucus barrier layer, there is increased bacterial translocation, and as a consequence, intestinal inflammation can arise. And because this AGR2 is not only expressed in the gut, but also in the lung, in some of those patients, there is a cystic fibrosis-like inflammation present as well. Inflammation and Crohn's disease cannot only happen in patients with an classical primary immunodeficiency, but also, for instance, in metabolic disorders. An exemplar is, for instance, Niemann-Pick type C. It looks like Crohn's disease can affect all ages, perianal fistulizing disease. And the pathomechanism is most likely that in those patients where a sensor of cholesterol is not functional, there is lipid droplet accumulation in multiple cells, including glial cells, hepatocytes, and macrophages. This is blocking the autophagy process, so the wrong metabolic signal, and as a consequence, bacteria cannot be digested, and Crohn's disease can emerge. Another exemplar highlighting the role of the immune system and showing that it's not always what it seems comes from a finding we have made recently in a collaboration with Paul Brogan's group from London, where a 14-year-old girl was studied with an infantile onset anemia, failure to thrive, hepatosplenomegaly, developmental delay, and where in the intestines there were granuloma-like features. Family was from a consanguineous background, and subsequently Paul had identified a genetic variant in AGR2 and in DNase2. And the DNase2 is a specific DNase expressed by macrophages. Macrophages with a defect can't digest DNA. This leads to an activation of the macrophages, and that leads to an interferon signal. And as a consequence of the genetic diagnosis, baricitinib was started and resolved this inflammation, including intestinal inflammation in this girl. And just to highlight what we thought are granuloma from that looked like Crohn's disease granuloma that was probably of macrophages that were ballooned, but had eaten DNA, but actually couldn't digest the DNA. And so it looked in H&E like multinucleated granuloma, actually very likely one macrophage that just full of DNA material, and presenting then with interferon responses, fever that were sort of resolved. Now, to summarize, intestinal inflammation enteropathies are an extreme complex group of that can be a presentation of a primary immunodeficiency, an inborn error of immunity. Age of onset is one of the key features. So if there is an age of onset under 1 year of age, likelihood is very high that this is an genetic condition. If there is infection susceptibility, features of primary immunodeficiency, complex autoimmunity, but also gut congenital disorders, congenital diarrhea, early malignancy. These are all features that should lead to genetic screening. As Jonathan has explained, there is a selective set of genetic tests that should be done, currently covering 102 genes. In addition, functional tests to look for chronic granulomatous disease, ITGAV deficiency, or lymphocyte subsets and immunoglobulins, but this is really a very limited set. In addition, one might now consider IL-10 autoantibodies as well. And to summarize, increasingly we understand that genetic diagnosis lead to precision medicine for these conditions. There are many different out-of-the-box treatments that have been tried. Clinical evidence is good for stem cell transplantation. Evidence that anti-TNF responses that we typically take on board in patients with IBDs, that they are not working, is high in a number of those conditions. And for other treatments, including, for instance, blocking IL-18 and ITGAV deficiency, IL-1 blockade and IL-10 signaling defects, for JAK-STAT inhibitors, CTLA-4 fusion proteins, and several others. There is now emerging evidence, but we need better data. If you hear horseshoe, so classical think, typically think horses, but not zebras. But in an immunology clinic, these are more often zebras than horses. It's all about the context. We need to exclude infection, environmental factors, and consider these genetic conditions. I'd like to thank many collaborators worldwide and my group, or our funders. Thanks for your attention.
Thank you very much, Holm, for a wonderful lecture and for sharing your expertise with us. So I want to remind everyone to put questions into the Q&A chat so we can have them at the end of the webinar. And now it's my pleasure to introduce to you Aleixo Muise, who will speak to us from Toronto, Sick Kids, where he's the senior scientist in cell biology program, but also the co-director of Sick Kids IBD Center. Is an expert in very early onset IBD and has actually studied many novel causes of very early onset IBD, and also developed animal models and corresponding organoids to study these conditions. So the floor is yours, Aleixo.
Great, thank you very much. I'm just assuming that everyone can see my slides.
Perfect.
Perfect, thank you. So I have no disclosures at this time. So as Holm and Jonathan both mentioned, we're interested in monogenic diseases. There are two main categories that we study. The congenital diarrhea and enteropathy, which are usually caused by single gene defects that affect the epithelium and often do not have inflammation, but may predispose to inflammatory bowel disease in the early teens. There is an overlapping group, the enteropathy group, with the monogenic diseases, monogenic inflammatory bowel diseases, as Holm has mentioned, so I won't go into much detail about them. Our group has discovered over the last number of years, often in collaboration with Holm, a number of monogenic diseases, including ARPC1B, which is involved in ARP2/3 branching, TD7 deficiency, sick, gain of function variants, as well as PLEVAP, which is a very interesting produced enteropathy. We've also discovered ITGAV, which I'll talk to you a bit more in detail, as well as a number of congenital diarrhea genes. What you probably know is that this field has been moving quite rapidly over the last number of years. So we've been able to contribute to a large number of diseases that have been discovered. And every year there's an increased growing number of diseases that seem to predominate in the gut that have been recently discovered. So as Jonathan mentioned, we did a study at Sick Kids where we looked at 1,000 patients, so all the patients in our inflammatory bowel disease clinic, and we were able to do whole exome sequencing of these cases, and we're able to identify approximately 4 to 5% of these patients actually presented with inflammatory bowel disease. What happens if you look at the very young patients, it is more common in infants, but we do see a large number of patients that are diagnosed after 6 years of the age or beyond the VEO-IBD age category. And Dr. Nambu from Japan, who was also in our lab, did a systematic review looking at the literature and also found that 10% of the patients that were described in literature also presented as adults. So while monogenic inflammatory bowel disease is more common in very young patients, it is indeed found in adolescents as well as adults. We did a similar study looking at 4 centers looking at congenital diarrhea in a very robust ethnic group population. And we actually found a higher diagnostic rate of 1 in 2 patients with congenital diarrhea. So they're presenting usually as infants with severe diarrhea that does not get better. And I won't go into much detail, but we did identify 3 novel codes of congenital diarrheas, and there is lots of overlap with monogenic inflammatory bowel disease. Mutations in MYO5B, which is a brush border defect, and you get these teardrop, the teardrop sort of intestinal in biopsy of the brush border, as well as MON1A defects, which is a defect in endosomal trafficking, which most likely has a combined immune as well as epithelial defect, and GRWD1, which is a novel ribosomalopathy. So really, most of the cases that we've been able to identify have been patients that have presented either to the GI ward or to our clinic. And this is just a number of cases that have actually gone on to bone marrow transplant and have been cured of some of their diseases. So the first case I'll just talk to you about today is a photocopy, which we think is similar to what Holm mentioned. It's our patient whose name is Lila. So she presented at Sick Kids at 4 years of age. She's actually native Canadian, and interestingly, there are a number of different subpopulations of native Canadians, and she's from this Moose Cree, which is in Northern Ontario, a very small population with a very small gene pool. And she also presented with microcephaly, retinopathy, infantile spasms, and mid-mental delay. But by 7 months of age, she had severe inflammatory bowel disease with vomiting, anemia, perianal disease. It also had some potential liver disease. She did seem to have a number of infections, but also widely spaced nipples, bifid uvula. And her mean workup, while it was negative, she did have a number of ongoing infections. And unfortunately, she did not respond to any of our normal IBD treatments, including adalimumab or vedolizumab, and required an urgent colectomy around 2 years of age. This is just the pictures of her colonoscopy showing quite severe inflammation. Interestingly, the family are not consanguineous, even though there is a small gene pool, and they previously lost 2 pregnancies. So interestingly, in this scenario, we identified a candidate gene called integrin alpha V. We found an amino acid missense variant that was highly damaging and quite rare. And as many of you will know, integrins always bind with a beta pair, so the alpha and the beta. Alpha V binds to beta 1, 3, 5, 6, and 8. It has a number of ligands, extracellular ligands as well as soluble ligands, and it's probably most well known for its role in TGF beta signaling. So in our case, our patient did have brain defects, microcephaly, malformations, and seizures, had retinopathy, had muscle defects, skin defects, liver, and GI colon-only inflammation. And if you knock ITGAV out in mice, you get a very similar phenotype, where the mice, most mice die soon after birth with both brain hemorrhages, retinopathy, and GI hemorrhages, and they also develop a colitis that's very similar to what we saw in our patient. This is also similar to the TGF beta 1 and TGF beta receptor defects that we also do observe. And this mutation has been this gene has been knocked out in a number of different mouse models, and people now believe that the mouse that develop colitis, it's most likely due to ITGAV lacking in macrophages, neutrophils, and dendritic cells. So interestingly, when we thought that this was a missense variant, that it was actually messing up function of the gene, but our poor PhD student did a number of assays and was unable to find any defect. So we went back to primary cells and we found that there was no protein being expressed and there's low level of messenger RNA. And what this missense variant did, it actually produced a novel splice acceptor that was stronger than the native acceptor site. So we had most of the transcript going from exon 1 into exon 4, missing the normal acceptor site, and leading to an abnormal transcript with a stop codon and no message being produced. So TGF signaling is quite interesting. TGF is produced as this propeptide. It's cleaved, and then it inserts itself into the extracellular matrix, where it requires cell stress before it becomes activated. So we were able to show that there was abnormal TGF signaling. We looked at fibroblasts as well as lymphoblastoid cell lines from this patient and found that the TGF signaling pathway was quite abnormal. We then looked at adherent junctions and found that ATGAV was not present here. And then we looked at focal adhesion, sorry. And we also went and looked at SMAD3 signaling, and we were able to show that in the patient's fibroblast, SMAD3 was actually lower and not being able to be phosphorylated or activated compared to wild type. And also there was decreased SMAD3 signaling in our patient. So indicating again that TGF signal pathway is abnormal in this patient. We then went on and found a second case with our collaborators in Paris. It was a patient from Portugal who also had developmental delay, eye disease, hyper-IgE, eosinophilia, ATP with lots of allergies and eczema, and very difficult to treat inflammatory bowel disease. Again, this is his colonoscopy, as you can see in panel B and C, which was quite severe. Unfortunately, he did not have a colectomy and has gone on to develop quite severe colon cancer in his teens, which is very unusual for these patients. We also see in panel D that he did have, in allergy testing, he did have what looks like he was allergic to almost everything that was tested for him. Interestingly, integrin alpha V binds to its beta heterodimer. And this is usually actually done in the ER, and then it's transported to the plasma membrane. And this requires a number of calciums, 4 calciums to be present. The mutation in this patient actually reduced binding to one of these calciums, and the protein actually got stuck in the ER and was not trafficked correctly, which could be the cause of this patient's disease. And then finally, we identified a third family, a Dutch family. They were not consanguineous, and they had two mutations that both resulted in splicing defects with complete loss of protein being made. And unfortunately, they had 4 out of 4 pregnancies were terminated due to severe brain malformations in these fetuses. So we went on to make a zebrafish model of ITGAV knockout, and most of the zebrafish actually died, but they did have brain hemorrhaging, as you can see in panel A, as well as gut hemorrhaging, as you can see below. We also looked at bulk RNA-seq from the zebrafish and found abnormalities in TGF signaling pathway. We looked at their eyes, and you can see this is a zebrafish eye with lots of vasculature, and this was very much reduced in our knockout zebrafish. Most interestingly, when we looked at the zebrafish bulk RNA sequencing, we found that the CCL34B was the protein that was the message that was most reduced, and this is actually a marker for microglia. So we looked at hopefully you can see in panel G, when we looked at a microglia markers, that in normal wild type zebrafish, we see lots of microglia, but in our knockout fish, we saw an absence of microglia. This suggests some of the brain defects may be due to loss of microglia, early injury that cannot be repaired with ITGAV knockout. In the gut, we were also able to show that most of these zebrafish died very early on, but the ones that did survive were smaller in size. They also had smaller body weight as well as body length. Their gut had quite abnormal architecture, as you can see in panel E and panel G. We also saw that looking at the gut-only bulk RNA sequencing, that there was increased levels of inflammatory cytokines. And we also looked at SMAD3 signaling, looking at phospho-SMAD3, which was greatly reduced in our ITGAV knockout fish. So this suggests this is a novel monogenic and inflammatory bowel disease with brain defects. It's characterized by this brain, gut, and retinal defects. In zebrafish, we have brain loss of microglia, the retina loss of vascularization, and the gut, we have loss of SMAD3 signaling. And it's quite interesting why these patients do get inflammatory bowel disease. So interestingly, there's lots of support for ITGAV in the role of typical or more common inflammatory bowel disease. In genome-wide studies, both ITGAV and integrin beta-8, one of its binding partners, are risk alleles, are risk SNPs. We also see that, similar to what Holm mentioned with IL-10 autoantibodies, we see high levels of autoantibodies in patients with ulcerative colitis. So there are two studies. A Japanese study looking at patients with ulcerative colitis found that up to 90% of patients with ulcerative colitis actually had autoantibodies to alpha V beta 6. And the higher level of antibodies corresponded to some more significant disease that was difficult to treat. And a second paper by the Mount Sinai group also showed that autoantibodies were present prior to diagnosis of ulcerative colitis, up to 10 years present. And again, higher antibody levels seem to correlate with worsening disease. There's also a recent paper that showed, looking at proteomics, that showed that ITGAV protein levels were reduced in ulcerative colitis. So there's lots of evidence that this seems to be an important driver of inflammatory bowel disease. Interestingly, there is no treatment that I know of for patients defective in TGF beta signaling, and most of these patients with severe disease end up with colectomy. And just in the last couple of minutes, I'd like to talk about a second case. So TT7 deficiency was another patient that was at Sick Kids. It's a female patient born at term, Caucasian mom and Sudanese dad, so not related, developed at birth severe diarrhea with basically a picture of the bowel being completely sloughed off with lots of intestinal apoptosis. Interestingly, these patients with complete knockout of TT7A have a severe multiple intestinal atresia. But if you have hypomorphic defects, you get apoptotic enterocolitis or VEO-IBD. And this is just showing that this protein is highly expressed throughout the entire intestinal tract. We know that it's involved in polarity. If you grow organoids, it actually will grow inside out. And we've been able to show that it's really involved in this PI4K signaling pathway, which is critical for cell survival, as well as polarity of intestinal cells. Work that Holm was involved in showed that if you have mutations in PI4K, you get neurological defects, but you also get a gut disease that is very similar to what we see in TT7 deficiency. And if we also see that a protein that we identified, UBR5. We think it interacts with TT7, and mutations in UBR5 actually develop inflammatory bowel disease, similar to what we see in TT7 deficiency. So unfortunately, TT7 deficiency, most of these patients die before their second birthday. What we see, if they have severe gut disease, for the immune disease, if you do a bone marrow transplant, these patients often do well for the first year, but the gut disease comes back, and they either have difficulties getting off the respirator post-transplant, or the gut disease comes back and they have very poor quality of life, or do end up having mortality secondary to their ongoing gut disease. So we did a high throughput screen looking for novel FDA-approved compounds that could actually resolve the apoptosis. We then validated this in a zebrafish model of TT7 deficiency, and this was secondarily validated in human organoids from a patient with TT7 deficiency. And we identified leflunomide, which is a drug commonly used in rheumatoid arthritis. And because this drug is off-label and the disease is rare, we were able to start a safety and efficacy trial to look at to see if this drug actually worked for patients with TT7 deficiency. And Jonathan is now trying to put together some of the results. Well, we know that there were no drug-related adverse events. So there's a black box warning about increased LFTs for these patients. Their preliminary results from our 10 study showed if you had the milder phenotype, we seem to have improved outcomes. And this was getting off TPN at an early age. And we have one case that is sort of illustrative, a patient from Buenos Aires. The patient is now four years old with a severe multiple intestinal atresia, as you can see here. He was started on flutamide and IVIG very early on in his outcome and has done extremely well, as you can see in this picture now, with a basically normal quality of life. So it's hard to know if this was due to leflunomide, but this is one of the few cases where a patient with severe defects has done that well. So we are hopeful that starting this drug early on may be beneficial for our patients. So as Holm mentioned, it's quite exciting that monogenic inflammatory bowel disease, from really its first identified IL-10 receptor defects in 2009 to now being standard of care in most places in Canada, the US, as well as Europe. So back to our initial patients. Many of our patients have had transplant and are doing very well and enjoying Canadian winter sports. To thank our VEO-IBD consortium, which Holm is a part of, as well as our congenital diarrhea consortium, and all our patients. So thank you.
Thank you very much, Alex, for a beautiful talk. Very interesting. So I invite all speakers now to switch on their cameras and join me for answering the questions of our attendees. So I'll start with Jonathan, maybe. So there's actually two questions that relate to the use of vedolizumab together with infliximab in the patient with IL-10 receptor deficiency. So is this, I'm thinking that this is not your first approach, that this is a rescue approach, and there are several questions on other patients that in the context of IL-10 receptor deficiency are not well controlled for their GI disease. Could there be a role for JAK inhibitors as well in bridging to stem cell transplant? So can you comment on those two items? Thank you.
Yeah, thanks very much for the questions. I guess the first question on dual biologic therapy, the question was not common in the management of IBD, was this choice based on evidence? So I think the Porto group have published the largest case series to date on the use of dual biologics of pediatric inflammatory bowel disease, with it primarily used in people that are refractory to a single biologic. And I believe in the paper it was people that had a partial response rather than primary non-responders. And you can get to clinical remission rates of about 50% at 6 months to 12 months, looking at that IBD cohort. And I think there's even higher rates of normalization of CRP and fecal calprotectin. And in that paper, the highest number of dual biologic therapies were a combination of the anti-integrin and anti-TNF. We have some experience at Sick Kids, and then I have some experience from Australia where we use it for secondary loss of response or incomplete response. And we've used it in about 30 to 35 kids. So it's something that we're quite comfortable with. And I think there is some emerging evidence that it is safe. Now, in terms of the other question about JAK inhibitors in the treatment of IL-10 receptor and bridging to stem cell transplant, my only experience was years ago in hematology oncology with myelofibrosis and JAK inhibitors. And I would have thought care would have to be taken because there's a difference between a loss of function of the JAK pathway and a gain of function. And considering the fact that the IL-10 is a potent anti-inflammatory cytokine, I think you'd have to be quite cautious about using a JAK inhibitor for this, but I might defer that question to people that are more experienced in the room, i.e. Holm and Alex. Thanks.
Thank you. Feel free to comment, Alex and Holm, on the JAK inhib question in the context of IL-10 receptor deficiency.
Yeah, so it's a very interesting sort of area because, of course, a textbook would tell us that IL-6 and IL-23 and IL-12 all signal to the same STAT3 sort of line as IL-10 does. But interestingly, sort of enough, if you look for, you need probably much higher doses of a JAK inhibitor to block the IL-10 as opposed to IL-23. So there might be sort of a really sweet spot where sort of you have a significant impact on the pro-inflammatory cytokines, but not yet take away the anti-inflammatory IL-10. Clear studies are lacking. There is sort of anecdotal evidence, but I think if we would have very worry about IL-10, then it wouldn't be as successful in the classical Crohn's disease and ulcerative colitis. I think there is overwhelming evidence that it has more beneficial pro-inflammatory effects as opposed to an impact on IL-10.
Thank you very much. Actually, again, a combined question is on the use of anti-cytokine, autoantibody panels. The case you presented, Holm, is very enlightening in that context, but also, Alex, so the study you mentioned from Sinai, where they show the autoantibodies against ITGAV already present before the onset of colitis. So those two reports really hint towards the need to perform those multiplex anti-cytokine or anti-integrin autoantibody panels. So can you both maybe comment on this aspect? How would you approach this, is the question. Go ahead, Alex.
Yeah, so that's a great question. I don't think that in my experience, we can't really screen for anti-cytokine or anti-antibody or integrin panel at this time. I think this is going to be the emerging, as we're seeing in many parts of monogenic intestinal disease or IEDs in general. So I think Holm's study is really illustrative. We think that's probably causative in that scenario. The ITGAV, it's unclear, but I have a feeling that it also is causative, especially with the higher titer levels. So I think this is going to be the next big step. But I'll let Holm answer because he is actually the one who published on IL-10.
So we are now starting to use it systematically, and what needs to be clear, and the data are still lacking. It needs to be better data. So what is an antibody that is just associated? What is an antibody that is maybe causative? And it probably requires a similar classification that we have for genetic variants. So there will be antibodies that are diagnostic. There will be antibodies that are causative and might be treated, but we need better evidence for this. And certainly sort of a large group of antibodies that have been tested for the last 30 years, ANCA, ASCA, sort of fall probably more in the diagnostic, if at all, category. They have not made it into clinical guidelines despite of decades of research. So that's probably sort of a degree. It's probably a bit like maybe, if at all, then it's a polygenic sort of contribution. It might be a clearance function. It might be just sort of a consequence of inflammation, removing sort of antigens, similar some of the antibacterial antibodies that we haven't discussed, sort of flagellines that might have a role, and mouse models suggest there could be some role. Are they just contributors? Are they modifiers? Are some pathogenic in combination with the right bacterium that needs a similar half a decade or a decade research as we have done in genetics?
Thank you very much. A more general question maybe for you, Jonathan, to answer from several people is, if you suspect very early onset IBD in a patient, what genetic analysis approach would you take? Would you go for clinical exome, whole exome sequencing as such, or what would you recommend as the first line workup?
Yeah, thanks. I guess just going back to basics, I guess the first line workup would be endoscopy and histopathology. And I know there's some questions about histopathological findings like apoptosis and severity of disease and villus blunting. And then I think Judith Kelson had quite a nice paper looking at the utility of immunoglobulin testing, then lymphocyte subsets, as well as vaccine responses, and then the VEO-IBD gene panels, depending on the area in which you work. And what agreements that your institution might have with what companies to make sure that it's not too expensive. We have a slightly different approach because of our in-house laboratory of pursuing proteomics and RNA sequencing and other sorts of genetic testing. But I would have thought that the most basic test is the basic serology endoscopy and then the VEO-IBD gene panels. Thank
you very much. Question for you, Holm. There is a question about somatic variants in as a cause of very early onset IBD. Can you comment on that question?
So it's a very interesting question. A few years ago, we came across a patient with an heterozygous variant in SUB-B in a male patient. And initially, we were worried that this would be a mix-up with a female sample. So we were just sort of following this up. This is sort of an error sort of in our database. But actually, it turned out that this patient had 70% chronic granulomatous disease, like monocytes, macrophages, neutrophils there, and 30% normal neutrophils. And as a consequence, the patient didn't develop chronic granulomatous disease because 30% of neutrophils are sufficient. It's a bit like transplantation and having a degree of chimerism there. In this case, it was mosaicism. And it doesn't seem to be too common. We tried now sort of to look more, but it's a very challenging field because if you have, for instance, an autoinflammatory sort of condition, then maybe a very small amount of cells might be sufficient. Maybe sort of 10% of an autoinflammatory sort of macrophage population could trigger sort of disease, but we will certainly miss it in our typical quality control features in this setting. Similar, it's possible that there are regional changes in the epithelium where all the time it's reoccurring. Is this an epigenetic imprint? Is it sort of a regional microbiome? Is there some degree of mosaicism sort of in the epithelium or in the mesenchymal sort of setting? This needs to be better sort of investigated. But in particular, gain of function variants, for instance, IL-6, ST, JAK, are the classical sort of mosaic condition with some selection bias and over time, maybe even accumulation of the population compared to the initial sort of setting. More deeper sequencing, single cell sequencing, single cell genomics, that's the field.
Thank you very much. Next question for you, Alex. There's actually 3 questions on TT37C. gene mutations and trichohepatoenteric syndrome. And so question 1 is, what would you recommend as the best treatment for these patients with the current knowledge we have? Another question actually related to the possibility to treat the patients with the Rho kinase inhibitor. And a final question was actually based on the treatment with leflunomide that you presented. Well, what would be the best timing to start these treatments in a newborn?
Yeah, thanks for the interesting question. So I'll go from the easiest maybe to the most difficult. The Rho inhibitor, the Hans Cleaver's group used that in their organoids, and Rho inhibitors are used to prevent apoptosis. We tried that in our zebrafish as well as our organoid models, and it had no response. So we don't think that is driving the polarity defects we see in our patients. For leflunomide, I think TDC7A deficiency, I think once you have end-organ damage, so I think there's thymus damage as well as severe gut damage, the drug will not respond. So it's very early on, but we would advocate for starting it as early as possible. The one case that I presented from Argentina, they did start it right at birth, one of the few groups that did, and have positive outcomes. All the positive cases we have so far, they've started it very early on in infancy or soon after or before diagnosis. So we think that is the case. So the most difficult question, and I don't know if Holm has any more expertise, but TDC737 is a really difficult disease. It's not the same as TDC7A at all. As far as I know, there's no viable treatments. We do get emails quite often about patients that are looking for help with that. There's nothing really beyond what we're able to suggest for. We've had some patients on anti-TNF if they do have more of an inflammatory bowel disease phenotype, and that does seem to help a little bit, but it does not resolve most of their problems. So I don't know, Holm, if you have any more insight into that difficult disease.
No, I think it's one of the tragic situations where sort of all the evidence suggests that all treatments actually sort of fail, and you almost have to discuss with parents that sort of sometimes stopping sort of increasing sort of treatment or stopping heroic treatment options is the best for the child. I've seen sort of these situations before where sort of clinicians often want to do sort of move forward and sort of do something, but that's not necessarily always the best for the child. And in this condition, it's probably one of the exemplars where we still need to find something better.
Thank you. So Jonathan, there's a question on the cause of mortality in IL-10 receptor deficiency and a linked question towards potential development of gene therapy for these specific conditions in the future.
Yeah, thanks. I think the largest systematic review looking at outcomes of IL-10 alpha receptor, and IL-10 beta receptor deficiency infection was the predominant cause of death, followed by lymphoproliferative disorders, then organ failure. And then I'll have to defer that question on gene therapy to maybe Alex and Holm, because I'm not aware of that yet.
Thank you. Any comments on gene therapy for IL-10 receptor deficiency? I'm not aware either, but if anyone could be, it would be you.
I think there are a few sort of efforts sort of ongoing, and certainly in vitro. I'm not aware of a clinical trial that's currently sort of prospective, open, or a company. Similar in IL-10, sort of there are some efforts clearly ongoing with preclinical data, and I mean, these new tools of lentiviral sort of are well advanced, and clearly sort of disorders that are well suited for this. and maybe IL-10 even better than IL-10 receptor, because the degree of chimerism is probably sufficient to produce enough IL-10 in the environment to calm down the system. So there are some conditions where you need to have a very high degree of chimerism, and some others not. And IL-10 would probably be one where you only need a moderate degree.
Thank you. So, Alex, there's another difficult question for you. It's a general question, but it asks for immunological tests and biomarkers that you would use to be directed to certain gene mutations in very early onset IBD, and the question for an algorithm. We already had it from Jonathan, but in a way, the approach that could be feasible to, let's say, not the experts in very early onset IBD, but to really distinguish, let's say, the pathway that is involved in the development of the condition.
Yeah, that's another great question. I think that's where the field is going towards. We don't have the data yet to answer that question. I think the thing that we know the most strongly are the age of onset. So if it's presenting as an infant, the likelihood of it being monogenic is quite high. So that's probably in the first few months of life. Even by age 2, we do see common polygenic inflammatory bowel disease more commonly. So it's the first few months of life. I think the other big hints are going to be family history of autoimmune disease. We see that quite commonly. And then the extra gut manifestations. So as Jonathan did mention, severe dermatological, other systemic disease is most likely the cause. At Sick Kids, we do try to sequence every patient who presents under the age of 2 and anything that a clinician finds to be abnormal. So most of our clinicians are very good. And if they found that the disease is atypical, non-responsive to treatment, then those are the patients. But I think in the next 5 to 10 years, and really the work that Holm is pioneering, we're going to be able to categorize most of our patients into pathways that are driving disease, and that should speed up this diagnostic odyssey quite quickly, and maybe also pinpoint the treatments. But I think right now it's still very much trial and error.
Thank you very much. A question related to that, and that's probably one of the last we'll have, is that the question whether in which, or if you can maybe group the monogenic forms of IBD that respond well or totally not to conventional therapy with anti-TNF, but I think it relates to the previous question. But can you, in large ways, make a distinction between those groups for the audience?
I'll let Holm try to answer that one.
Anyone who wants to answer?
So typically, there are very few conditions. There are some conditions that are moderate macrophage antimicrobial defects. So NPC and Hermansky-Pudlak syndrome are these syndromes that are not clear primary immunodeficiencies, but have a significant impact. So having an IBD penetrance of about between 5 and 20%, so relatively moderate age of onset in the median as adolescent age, and those seem to be well treatable in at least in a significant proportion of patients with anti-TNF treatment. With the vast majority of all other treatments, it isn't. And the best indicator is that these patients are not long on anti-TNF. So they're switching from drug A, B, C, anti-TNF 1, anti-TNF 2, and then go forward in a sequential. And that typically is the indication. But clear systematic analysis is very hard to do, because the outcome measures are so heterogeneous. What people describe in their case reports, case series, is not standardized and doesn't typically allow even to learn from the literature, other than works, potentially works, partially works, or doesn't work. And of course, this is not the science and the evidence that we need in the field.
Thank you very much. I have maybe a final question for you, Holm. So the Niemann-Pick patients, do they respond in terms of bowel disease to the new compound that has now been approved for the neurological deterioration, or do you? I don't know if there were any patients on that trial with IBD, but it could maybe also be supportive. I think it's the levo. What is it? Acetyl, but not a cysteine, but a leucine, right?
Yeah. So I just attended sort of a Niemann-Pick sort of international conference, and what is clear is the majority of treatments that have been used in the past, including miglustat, for instance, or some of the compounds that are sort of in the protein folding sort of machinery, they certainly do not have an impact, clearly not. There is not yet any good evidence for these new treatments and metabolic treatments. But last year, I think 2 or 3 new drugs are approved by the FDA, and data will come up.
Okay, perfect. Final question, Alex, for you. Have you seen IBD in patients with cyclic neutropenia? I don't.
Yeah, I have not seen any, but in our cohort of patients as sick kids, but
Yeah. Okay, I think it's an interesting question because, of course, it could be related. But so I think we've answered, at least for now, most burning questions. So I thank you. Jonathan, you have your hand up. Sorry.
Sorry, I was just going to say that the person who asked the question about TT7A in one of their patients and leflunomide, happy to make contact afterwards if they wanted to.
Thank you very much. So thank you all for your lectures, for contributing to the webinar, and for answering all the questions. Thank you to the attendees. I have a few slides, I think, for ESID. Thank you very much to all of our speakers. First of all, I want to highlight that with all the societies, the scientific societies, we created an International Alliance of Primary Immunodeficiency a long time ago. And together with all these societies, we actually mounted a new journal that is really focused on errors of immunity and on human immunity in general. So I want to invite all of you to submit your interesting cases and reviews to this new journal. That is definitely the home journal for our field. As a next item, I want to highlight the upcoming fantastic joint symposium between CIOP and European Association for Hematology and ESID, which will be in November. And please save the date for this meeting. It's going to be in Vienna. And please don't forget the deadline for the abstract submission, which will be on the 10th of June. It's going to focus on the interplay of immunology and hematology, which is just like the interplay between immunology and gastroenterology, a field of growing interest. So please mark your agendas. And then also upcoming, but with a closer deadline, is the fellowship for ESID junior members. The call is on the website, and the deadline is 9th of May. So please learn more about the benefits also of ESID membership. And one of the benefits is that you can apply for such fellowship. So please have a look at the ESID website. And then also I want to highlight the upcoming diagnostic workshop in 2025. You have to submit an application, which should be prior to May 25, so also quite close this deadline. It can really help you expand your knowledge on flow cytometry, on diagnostics that are common to inborn errors of immunity labs, and that can really elevate your the level of diagnosis that you can make. So please submit, if you want, an application to be present at this diagnostic workshop, which is almost yearly organized, if I remember well, but which is really a great asset to all who want to study further in the field of errors of immunity. So I think that's the last slide, and that's the end of this webinar. And thank you all for joining. I'm sure you will be able to follow up if needed with the speakers. And the recording will also be available for, from the ESID website. So thank you very much.